Hi, this is Brian Kim. I'm going to share with you case number 234 in the Best Way to Do Cataract Surgery series. And the purpose of this title is not to suggest this is the best way, but to get you to think about your best way to do cataract surgeries, which means you want to think critically about your technique, think about other ways to refine and enhance your technique so that you can provide the very best for your patient. So this is a moderately dense lens with a large pupil. You're going to see there's quite a bit of zonular laxity because this is a high myope. And it can be a little bit of a challenge because the lens is a little bit wobbly. The lens sits more posterior. And you're going to see how I'm able to leverage mechanical fracturing, double chop, and cross chop to disassemble this lens. So using the cotton tip to steady the eye, use a corneal marker, which will help me to center and size the rhexis. Make a paracentesis incision first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine. And then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. As I push that viscoelastic, look and see that the lens got pushed back quite a bit posteriorly. Again, just sharing with you and verifying and confirming that, yes, this patient does have some zonular laxity. That's confirmed with that viscoelastic. As I push it, the lens really bows back quite a bit here. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea. So I did a little bit of a wiggle and then I entered here. This is the microforceps with a sharp tip. It opens up, the teeth open up really nice and wide. I have the cannula there to push any more viscoelastic if I need. And I do prefer now this two-handed technique when I do my rhexis. I puncture the center, pull down towards me, grabbing the right side of the tear, going around circumferentially. Again, I'm trying to use that corneal marker as a guide. But you see here, as I'm pulling, look at the ripples within the anterior lens capsule. As I'm pulling the flap for the rhexis, the leading edge of the capsule is folding upon itself. Again, that is a sign of that zonular laxity that I was talking about right there. And all those ripples are just a sign that, there's not as much zonular counterforce, and there's a little bit of zonular laxity and weakness there. Going around again circumferentially, going around, grabbing and re-grabbing. I have that cannula just in case if I need to do anything more as far as pushing more viscoelastic. It does, again, allow me to control the eye as well. Finishing off the rhexis. Burping some viscoelastic out. Placing some viscoelastic on the corneal surface. And this is the capsule fornix hydrodissection technique. I'll place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, lift the lens up a little bit, trying to decompress the bag as well. Again, there's some zonular laxity, so you want to be mindful of that. And when it gets this way, sometimes it's a little bit harder to rotate the lens. But fortunately, in this case, the lens begins to spin. Going in with irrigation off, activating irrigation, lifting the incision with the chopper, lifting the iris as I'm activating the vacuum because I wanted to avoid reverse pupillary block, placing the chopper around the rhexis edge contra-incisionally, rotating the phaco tip vertically sub-incisionally, fracturing the lens completely in half, placing the chopper around the right heminucleus, hooking the peripheral lens, crushing it against the phaco tip, pulling it centrally, and fracturing the right heminucleus in half, placing the chopper around the first quadrant, hooking the peripheral lens and then pulling it centrally toward the phaco tip, fracturing the lens in half, and then using some vacuum to grab those fragments and then crushing the lens into smaller and smaller pieces and then emulsifying the lens piece. So that first quadrant's gone. separating the second quadrant from the rest of the lens, placing the chopper around the lens, hooking the lens equator, pulling it centrally toward the phaco tip, fracturing that quadrant in half, using some vacuum to crush the lens into smaller pieces, and then emulsifying the lens pieces. You can see as I'm doing this, the entire bag is a little bit kind of a wobbly effect. Again, just kind of validating and confirming what I said earlier, which again, I felt like there was zonular laxity when I pushed the viscoelastic in. The whole lens bag complex went backward. And then when I was doing the rexus, you can see the wrinkling of the capsule. Turning the second heminucleus in front of me, placing the chopper around the lens, hooking the peripheral lens, pulling it centrally toward the phaco tip, and crushing the lens in half. Again, another cross-chop maneuver, performing the same maneuver around the third quadrant. And you saw I had to use a little bit of vacuum to basically reposition the lens, which is fine, and then crushing the lens with the instruments which are flanking the lens, and then again using mechanical fracturing forces to break it into smaller pieces, and then emulsifying the lens pieces. There's nothing wrong with using a little bit of vacuum to grab the lens piece to position it. Again, vacuum is like anything. It's like a gun or a knife. You know, if you use it correctly, it's very effective to do what you want it to do, but if you do it in the wrong way, those instruments can be harmful. And so it's the same thing with the phaco tip and high vacuum. Now I have this loose fourth quadrant. I'm just positioning the instruments around the lens, crushing the lens between the instruments, getting under the lens with the chopper. Again, by utilizing only infusion pressure, I'm able to very carefully position the phaco tip and the chopper around the lens, not utilizing vacuum or ultrasonic energy as I'm doing these things. But once the lens pieces then are separated, then I'll start to emulsify the lens, again, activating ultrasonic energy and vacuum for that purpose. So again, while I'm trying to disassemble the lens, the phaco tip is acting like a chopping instrument. No need to use vacuum. Actually, it's bad to use vacuum in that context because you don't want to accidentally grab the posterior capsule. And so I'm able to very carefully even position the phaco tip deep in the bag. And it's okay because even though I'm close to the posterior capsule, I'm not activating any vacuum or aspiration. I'm able to, again, position the instruments around the lens, crush the lens with essentially two chopping instruments. And then when I'm ready to emulsify, then I can initiate the vacuum and ultrasonic energy. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I always start subincisionally when I can, trying to peel anterior to posterior. By doing it this way, you get a cleaner peeling of the cortex off the capsular bag. And as I'm peeling, you can tell the relative zonular laxity. As I'm peeling, there's not as much holding power of the zonules as I'm peeling off the cortex from the capsular bag. And you can feel it as you're peeling that stuff off. So it's mindful to think at every step and really just being aware as a surgeon about all of these things. Because if you're not aware and you're just kind of going through the motions, doing the surgery, then you can get burned. You can be like, oh, didn't expect that to happen. And you get a posterior capsule or you rip the zonules accidentally. So it's very important. Switch to polish mode, polishing under the rexus edge. So again, if you go back and see as I'm removing the cortex, you'll see as the cortex is being pulled, it's causing some stria in the posterior capsule. Again, I didn't pause it and show it, but I did see evidence of that here as well. So again, at multiple phases of the case, evidence for zonular laxity. Using the BSS cannula to pulse into the capsule fornix, able to eat a little bit of that cortex with the INA handpiece, filling the bag with cohesive viscoelastic, turning off the infusion as I do this, and then using the sweeper to polish under the rexus edge, first on the left side and then the right side, making sure I remove the lens epithelial cells and any potential cortical material that might be left behind. Again, you see this big bag. Again, this isn't a high myope. Big bag, big eye, big pupil, a little bit of zonular laxity again. saw the zonular laxity when I pushed the dispersive viscoelastic at the very beginning of the case. The whole lens bag complex kind of pushed backwards. Saw some stria within the anterior capsule and creating folds as I was doing the rhexis. And finally, during cortical removal, you can see some stria lines in the posterior capsule as I was peeling off the cortex. So again, do I need to put a CTR in this case? No, I don't think this is necessarily weak zonules, like in a patient with pseudoexfoliation or something like that. This patient is not really that old. This patient is really just, again, a high myope. And there's naturally some zonular laxity in these situations. So I did not feel like a CTR was necessary. Went ahead and placed this single piece of acrylic lens in the capsular bag, getting under the lens, removing all the viscoelastic, polishing under the rhexis edge. You see, it's just a beautiful, big pupil, nice, deep chamber. Really kind of, in a lot of ways, the ideal surgery for even a resident. I think the only downsides was, like I said, the zonular laxity, which you have to be very mindful of. Removing all the viscoelastic from within the anterior chamber and hydrate my incisions after this. So again, moderately dense lens, big pupil, some evidence for zonular laxity. And remember, it's very important to be mindful throughout the entire case of any potential problems. So as I filled the anterior chamber, the lens bag complex pushed posteriorly, again, a sign of zonular laxity. During capsular rhexis, I saw some stria within the capsule, anterior capsule, creating some folds as I was pulling the flap. And then finally, as I'm peeling the cortex off the bag, there was some folds and stria within the posterior capsule. So again, very careful not to exacerbate any problems. Again, otherwise a normal case, but these cases can potentially become a bad case, especially if you have techniques that are really rough on the zonules, especially if the lens is stuck to the bag. You don't want to use aggressive torque to free up the lens because the zonules are being damaged when you do that. You can see as the eye is moving, you can see a little bit of jiggling of the lens. But again, overall, nice routine case. And knowing how to handle these cases of loose zonules and leveraging mechanical fracturing forces and techniques. So I hope this was helpful to you, and I thank you for your attention.